Thank you for that kind introduction, and thank you to the course directors for inviting me to be here today. It's truly an honor. These are my disclosures and our statements on cultural competency and implicit bias. We're actually going to talk about some of that in a later slide. So I have good news and bad news about pancreatic cancer, and I should have started by saying that the focus of this is going to be primarily pancreatic disease and pancreatic cancer. So if we look at 5-year survival using SEER data, we can see that patients that are diagnosed with localized disease, as shown in the blue line in the top of the graph here, have seen remarkable gains in terms of survival. 20 years ago, when I give this talk, the survival, even for localized disease, was still very poor, only above 20%. Now we see survivals exceeding 40%, and those have been maintained. The bad news is that we have made almost no headway in terms of locally advanced or metastatic disease, shown in green and lavender, and these patients just don't survive when they are not diagnosed early. So this is even more the case for patients that have early stage disease and can actually make it to resection. These patients have the best survival. So this is data looking at survival for stage 1 pancreatic cancer in patients that undergo resection, shown in blue, compared to those that do not undergo resection. And though not fantastic, the survival out here to 90 months is greater than 40%. So these patients have to have early stage disease, and they have to make it to surgery to change their outcomes. So this pictorial actually nicely depicts what we think about when we think about early detection. So we know, like pancreatic cancer, like all cancers, progresses from stage 1 to stage 4 disease, more advanced, and we know that in patients that come to clinical attention and diagnosis through natural presentation, in other words, they're not part of a surveillance or screening program, those patients end up with less than 12 months survival. They develop through these stages, often presenting with stage 3 or stage 4 disease, and they die within 9 to 12 months after presentation. Compare that to patients that are in a surveillance program. So these patients are having regular screenings, and we'll talk about what that is in a minute, and they get diagnosed earlier. So we do see lead time, and we'll talk about lead time bias in a minute, but those patients at least know that they have cancer earlier. They have those months of survival where they have it. And then if you look at what happens and what we believe happens, and I'll show you several studies that do confirm this, these patients not only get that lead time bias for survival, they get earlier stage diagnosis, and they have improved survival overall, leading up to more years of life even after diagnosis. So the whole notion of early detection improving survival in pancreatic cancer, there was not a lot of data until recently that was true. We believed it based on other forms of cancer. We knew in breast cancer, and colon cancer, and cervical cancer that early stage diagnosis led to improved survival. But there was not a lot of data for patients with pancreatic cancer. Many of us, myself included, believe that even patients diagnosed with early disease still were likely to die from that disease. This is a study that was published a couple of years ago and came from the Netherlands. And here they looked at patients that carried a CDKN2A mutation, and they were in a surveillance program. And they compared patients that had cancers diagnosed in that surveillance program, and they matched 31 patients to 1,500 patients that had sporadic detection of their pancreatic cancer, because they wanted to see what happened with those patients' survival in those two different scenarios. And what you can see in the graph on the right is that the patients that had their cancers detected through surveillance, shown in blue, had significantly better survival than patients that had them diagnosed sporadically. This was through the Netherlands Cancer Registry. And not only that, patients that were detected through surveillance had earlier stage disease, and they were more likely to go to surgery, going back to that concept that I made earlier, that if you can make the surgery, you're going to do better. So what data do we have in the United States? So I'm sure Dr. Tomasetti is very familiar with this. This is the CAP study that is led by Johns Hopkins University. And this was one of their earlier publications where we were watching patients at multiple centers using a combination of EUS, MRI, and CT scanning. And in this publication, what they were able to show is that 68 patients that were in the surveillance program developed worrisome findings, like a solid mass on imaging, or a dilated duct, or abrupt cutoff, or things like that. And then they went to surgery. Out of those 68 patients, 24 were found to have pancreatic cancer. That's the line shown here in purple. And then they compared their outcomes to patients that had sporadic detection outside of surveillance. And you can see here that there's a remarkable survival advantage for the patients that were in the surveillance program. One of the things I think is really important to point out and think about, and Dr. Tomasetti talked about this, is we want to find pre-cancer, right? Those are the patients that do the best. And you can see that in this top line. So a portion of the patients that went to the OR in the surveillance program turned out to have either IPMN with high-grade dysplasia or Pannin 3 lesions. Look at their survival. It's almost 100% across the board, getting back to that notion of detecting cancer before it actually happens. This is the most recent publication from the CAPS trial, and this is comparing patients that had their cancers detected through the surveillance program, and then comparing those outcomes to patients with pancreatic cancer through SEER data. And what you can see here again is that there's a remarkable survival advantage. The patients had earlier stage disease, even when this study accounted for lead time bias. So going back to that concept that I said earlier, we have some bias here. When this study controlled for 3, 6, even 12 months of lead time bias, they still had a survival advantage in the group that were detected through surveillance. So why does this seem so hard? And I want to come back to a point made by our speakers earlier about false positives and what that does and how that affects us. And I've used this particular slide in almost every talk I've given on early detection. This is not an exception. And I'm trying to get across to you how hard this is in pancreatic cancer for the general population. So let's say that we're screening everybody, that tomorrow I had the best test that Dr. Tomasetti could invent, and I could submit it to everybody in the entire country watching for pancreatic cancer. The general population risk for pancreatic cancer is around 1.3%. So let's imagine a cohort of 10,000 people. We do Dr. Tomasetti's test in them, and one of those patients, because I've already told you about the incidence going in, of that 10,000 has cancer, 9,999 do not have cancer. And I have an amazing test. My test is 100% sensitive and it's 95% specific. If you use that cohort and do that test, you're going to come up with 1 true positive and 499 false positives. And so what are you going to do with that information? How does that affect patients and their families? It does. So the answer right now is to improve or enhance the cohort's risk that you're doing the testing in. And this diagram nicely shows all the different risk factors that we think about when we see patients and determine their pancreatic cancer risk. So is anybody in the audience in primary care, and APP, anything like that? Raise your hand. So some are. So if you don't take home any other message from me today, take home the message that if you're seeing a new diabetic that has normal weight, normal BMI, and no other reason to be diabetic, one of the things that should come to mind for you is, does this patient have pancreatic cancer? Research from the Mayo Clinic has shown that that diagnosis can precede the cancer diagnosis by as much as 2 to 3 years. So other risk factors include things that we know about: pancreatic cystic neoplasms, chronic pancreatitis, genetic mutations, we'll talk more about that in a minute, increasing age, and then blood type. It turns out that the more non-O type blood you have, the more likely, the higher your risk is for pancreatic cancer, with BB blood type being the highest. excessive alcohol use, so watch what you're doing this weekend in Las Vegas. Smoking, family history, of course, and then obesity. This is the case in many cancers. Right now, in terms of screening and surveillance, the only two that we are using in guiding our surveillance and screening is genetic mutations and family history. So right now, the United States Preventative Task Force recommends screening for patients that have a pathogenic gene variant, those with a mutation and family history, those with a familial pancreatic cancer kindred history, and it varies by guideline, but for the most part, it's at least 2 relatives with pancreatic cancer, and 1 should be a first-degree relative. And then, of course, PRSS1. PRSS1 is also known as the hereditary pancreatitis gene mutation, and those patients have a significantly increased risk for pancreatic cancer, especially if there's a paternal inheritance of that gene mutation. And so the task force recommended screening in that population as well. They explicitly say, do not screen the general population for the reasons that we just talked about. This is a slide worth getting your camera out and taking a picture of, because if you're in clinic and you're seeing these patients, it very nicely summarizes all of the gene mutations that we actually screen and survey patients for, and then what that patient's lifetime risk is with a range, and then what age to initiate the screening at. So you can see at the very top of the screen, we have STK11, which is also the Peutz-Jeghers gene mutation, very high lifetime risk, and CDKN2A, the second most high risk for pancreatic cancer. That, of course, is the FAM gene mutation, or familial atypical multiple mole melanoma. And then the other genes that I've listed are also included. Where you see notations of a superscript 2, those are cases, or mutations I should say, where most guidelines recommend that you only do screening and surveillance if the patient has a family member with a history of pancreatic cancer. I will tell you that many patients will come to you with those mutations and without a family history, and they still want to be screened. And we can talk in the question and answer about how people handle that. But carrying those gene mutations is a huge burden to our patients in terms of their worry. Okay, I mentioned that we were going to talk about how do we screen. This varies by guideline, but most guidelines recommend that you do endoscopic ultrasound or MRI with contrast annually. I will tell you that our group generally uses an alternating, in high-risk genetic mutation patients, we alternate EUS with MRI annually. I will tell you that there are guidelines that say because the risk in the STK11 and CDKN2A mutation patients is so high that they recommend every 6 months. And there are even some guidelines that recommend both EUS and MRI annually or every 6 months for those particular mutations. Many of us will do annual CA19-9 more to understand what the baseline is, not as a screening. I do hemoglobin A1C in all of those patient populations because of going back to that diabetes comment that I made earlier, right? So if you see that the hemoglobin A1C is rising over time, that's going to alert you that something might be changing in that patient. You might change how often you're surveying them or what you're using. And of course, we'll update the genetic test results and the family history at the time of an annual clinic visit. So many of us use endoscopic ultrasound for screening and surveillance in these patient populations, and I think it's important to point out and emphasize that we need to have a systematic approach to doing this. We should be including in all of these reports, our EUS reports, the indication for the procedure, and then we should be using a systematic approach in terms of image capture and what we describe. That includes the parenchymal evaluation, the size of the pancreatic duct, whether it's changing, and the common bile duct size as well. We should describe solid or cystic lesions, and we should assess and include the quality of the exam in the report. So these are figures. The ones to the left of the green bar are essentially stations that should be included in all EUS exams that are standard images that include the entire pancreas, the uncinate, the head of the pancreas, the body, the tail, the blood vessels that you're looking at. And if you are somebody that do EUS, I would encourage you to become systematic in that approach, and that will help you as you watch these patients longitudinally. The images on the right are the changes that we see in these patients that carry these gene mutations, and these can be things like hyperechoic foci, stranding, lobularity, and I will tell you, almost without fail, when a patient carries a gene mutation, they don't have normal pancreas. And my theory is that those patients have an increased sensitivity to environmental insult, and that even if they don't drink and they don't smoke, they don't have normal pancreas. It's really remarkable. We should do a study on this. So I want to talk about barriers to screening and how that affects our patients. So income plays a huge role. There are multiple people in our country that are either uninsured or underinsured, and those are patients that are not going to come in and get screening and surveillance. They just can't afford it. Geography. We in Phoenix, Scottsdale area are blessed to have abundant, good medical centers and resources, but that's not the case. There are healthcare deserts in this country where patients can't get quality screening exams. That's a real thing. I want to spend a minute talking about social isolation, and this is what I mean. Probably everybody in the room has friends and family that can take them to tests and bring them from tests, but there are many people that don't. If you are somebody that lives away from your family, or you don't have anybody because of whatever the problem is, how do you then present for a screening exam? How do you get a driver? How do you afford that? And that's definitely something that lowers our screening ability. Language is another barrier to screening, and there is definitely a mistrust among certain populations and the medical profession for good reason. And then finally, whether or not we acknowledge it or not, whether it's conscious or unconscious, there is provider bias. And we heard about some of that in an earlier talk in terms of patient care. So this is a study that looked at race and ethnicity in pancreatic cancer surveillance. And the dotted lines, they're a little bit hard to see, but can people see that there's the dotted lines here? That's what the US Census population is for those particular groups. So for example, 50% or 58% of the US population is considered white, 18.7% is considered Hispanic. And then overlaid on these bars is the proportion of patients that are in pancreatic cancer surveillance programs across our country. They're all white people. Like, we're not doing a great job of enrolling patients that even have a higher risk and a worse outcome of all things in surveillance programs, so we definitely need to do better. I'm going to close with one more study and 2 more slides on future directions, and I'm so happy that the previous speakers didn't steal this one. So this is a study that created a convolutional neural network, used AI, to improve or augment endoscopic ultrasound imaging. And so they took thousands of images from patients that had different pancreatic conditions, including autoimmune pancreatitis, chronic pancreatitis, pancreatic cancer, and normal pancreas, and they trained that neural network. They then validated that using an independent cohort of patients, and then they tested it in a real-time study where they compared results of the CNN to endosonographers. And here's what they saw. In all cases, the convolutional neural network outperformed human endosonographers, roughly 50% to 80% in terms of sensitivity and specificity. So whether you are an early adopter, a hater of AI, put it on the back shelf, we need to realize that this is coming and this is going to be part of our practice, and so we should adopt it and begin using it. Thank you.